right, welcome to another of our webinars on restarting and energizing patient and family advisory councils with easy to implement how-to lists. Today, we're going to be talking about diversity and inclusion on patient and family advisory councils. This can apply in a number of different areas. We're really excited to welcome DeeJo Miller today, who is the Patient and Family Engagement Program Manager, or A. There's also Cheryl. Hi, Cheryl, if you're on, at Children's Mercy in Kansas City. And I am Lisa Maurice, the Executive Director of Consumers Advancing Patient Safety. We're going to see if we can get this to advance. Today, we're going to cover definitions of diversity and inclusion, 4 steps to a diverse patient and family advisory council, and that is what the acronym PFAC stands for. We're going to look at the demographic considerations that a lot of people have top of mind and go to for diversity issues. We're going to look at other important considerations. We're going to talk about recruiting for achieving diversity, practicing inclusion on patient and family advisory councils, and DeeJo is going to share with us some of the exemplary practices that Children's Mercy has put into place. So we're going to start out with diversity and inclusion. Diversity is the practice or quality of including or involving people from a range of different social and ethnic backgrounds and of different genders, sexual orientations, etc. These are those demographic considerations we'll get to. Inclusion is the practice or policy of providing equal access to opportunities and resources for people who might not otherwise be, or who might otherwise be excluded or marginalized, such as those who have physical or intellectual disabilities and members of what we look at as minority groups or demographic groups, or again, those other considerations. It's almost a mystery, isn't it? So let's talk about 4 steps to achieving a diverse PFAC. And there's a link here to where these 4 steps are listed by at Brandeis University. And these come from, I believe, a NICHQ related research effort. So the 4 steps are to collect data on the composition of the patient population. You can't be representative of your patient population if you don't know who they actually are. We have found at Consumers Advancing Patient Safety that data collection is one area that medical facilities, hospitals, and ambulatory care could really improve upon, because one of the highest categories, for example, of reporting ethnicity, or what we sometimes call color of skin, is didn't answer or don't know. And that often relates back to a training issue at the collection point of care. So that is something that you can work on to improve overall diversity and inclusion in your facility, is improve your data collection. You have to know who the people are. Another is to use a multi-pronged approach to patient and family advisory council member recruitment. Just one path generally won't reach your entire universe of patients and families. So using more than one approach is so important. We'll talk about some of those options in a few minutes. Showing a commitment to diverse communities is very important, and that is done through messaging. So all of your for example, social media pictures that you show don't all show one specific group of people, that there's a rainbow of individuals, not unlike the picture on this slide where you see people from multi-religious backgrounds, multi-ethnic groups, multi-occupations, multi-abilities. So we want to see that differences are spread across your entire group. And finally, empower patient and family advisory council members to contribute in a meaningful way to organizational improvement. When your patient and family advisory council becomes basically just a stamp of approval to what you're sharing with them and isn't giving meaningful input and involved at the very root level of your organization, then you're really not practicing inclusion. You're just looking for people to say, good on you. And sometimes that's not what patients really want to be involved in. Demographic considerations, gender. This has become an issue that is not just bilateral any longer and is something that's important to be aware of and up on. There are multiple genders, and how a person identifies is very important, and it impacts their medical care significantly. So it's important to consider inclusion of non-traditional bilateral genders in your PFAC efforts. Race and ethnicity is probably the most obvious one, but is it really? Because, for example, you might notice, blonde hair, at least it was once, and blue eyes. I have a sister who is African American. You might not think that, but when we tell people we're sisters, they always go. So race and ethnicity is not always easily apparent. I am also a significant portion Indigenous background, and you wouldn't think that either, but it's true, and it has impacted my heritage and my ancestors. So you need to ask people what their backgrounds are, and this gets back to data collection. Language spoken is very important. That includes everything from non-native English speakers to people in our community who were raised in homes where English was a second language, to persons who communicate through sign language. All of these things need to be taken into consideration. Religious background is particularly important, especially in communities where a specific faith may dominate the community. Make sure other voices are heard so that you have those inputs about what is important to people. Socioeconomic factors include income. They can also include what zip code a person is. We want to know relationship status. I am a divorced woman. That impacted my childcare and my caring situation when I had a child that was hospitalized frequently, in fact, many times a year. It was important to know and ask how I was handling that. And it's important that I be represented on a PFAC. Educational level and cognitive level. I cannot emphasize enough that it is so important to ask individuals who you may think don't understand everything to be on your PFAC, and it's incumbent on you to help explain things in a way that they can understand. I've served on a number of advisory panels where individuals who one may not think were necessarily going to be contributing because their education level was lower or their cognitive level was lower, provided tremendous insights into their experience with the system and how the system could best serve their needs. So I think it's very important because their insights are unique to their situation. I've also served with people who were proud to say they did not have a college degree, but the reality was some of these people could run circles around some of the administrators that they were working with in terms of their knowledge of issues like how to navigate Medicaid or how to care for a child at home who had a medically complex condition. So I really want to see people reaching out to individuals who don't have master's degrees. In terms of type of residence, you want to look at people from multiple dwellings, apartments, single homes, attached homes. We want to see diversity there and diversity in terms of what they have access to in their homes. Not every home has the internet, for example. If you have a member of your PFAC who doesn't have the internet and you're reaching out to your PFAC primarily through email, are they going to be able to receive that? That's something that needs to be assessed and something to be aware of, because that impacts your patient population too, and you may want that representative voice on your PFAC. You also want to look at sexual orientation and, again, gender identity. Other considerations. These are things we don't always think of, but that are really so important. One is the medical condition or the disability that a person has. You may have a tendency to load up on individuals from who have experience in, for example, oncology on your PFAC. And that would leave out everybody who had maybe a transplant or your cardio patients. So it's very important to look at diversity across your service lines that are going to be represented on your PFAC. Now, sometimes a PFAC will be specific to a service line. In that case, clearly everybody's going to have a similar overarching diagnosis. But again, if you're serving a diversity of diagnoses, subdiagnoses within that overarching term, you're going to want diversity in terms of the people that are representing and talking on that PFAC. You want the geographic location to be considered. So, for example, here in Utah, we really have an urban environment in the Salt Lake Valley, and we had most of the people who were serving on the children's PFAC from that environment. But we also had people joining way back 10 years ago by phone. We didn't do Zoom then. That were from rural environments who had to travel significant distance to experience the hospital because their experience was going to be different and their insights would improve the vast number of people who were coming to the hospital from a great distance. It would improve their experience. We want to talk about their lived experience. The lived experience of an immigrant is going to be so much different, for example, or a refugee person than somebody who is from a quiet upper middle class background. We want those experiences to be represented on the PFAC. And finally, what is their primary care site? Are you pulling in individuals who are served at specific organizations that are affiliated with your hospital? For example, those that may be owned by the hospital system, or maybe also some who are from federally qualified health centers or from school-based clinics. If you're a pediatric facility, you want diversity there. And, you know, I keep talking about all of this diversity. Let's talk about recruiting for that. And let's talk about the fact that you only have maybe 8 to 12, maybe as many as 16 PFAC slots. And how are you going to make all of these people different? Well, you're not. You're not. So let's all take a deep breath and think in terms of, you just don't want everybody to be the same. And you can't get every group represented, but try for diversity. Contact community organizations, nonprofits, and local advocacy groups as part of your outreach. Don't look at trying to have allocation based on a certain percentage of the population, but just that people are different. And be sure to include that demographic and other consideration information on your application so that you can maybe not interview everybody who is the same, but look for those differences to fill the slots on your PFAC. In terms of practicing inclusion, you want to encourage the sharing of diverse perspectives and considerations. Now, especially if your facilitators of your patient and family advisory council are from one demographic group or one ethnic group, others may be less open to sharing and need to be welcomed in. So we've talked before about how to help people communicate on the PFAC and the importance of facilitation. You may want to recheck that video for some clues about how to get people to contribute. But one of the most important things is to create a safe environment for sharing. Let's not be correcting people immediately if they say the wrong word, but we know what they mean, for example. Provide interpretation if there's a language difference. Try to reach people ahead of time with information about acronyms and other terms that may come up in discussion. Provide childcare for people and set your timing and transportation options that fit the people who are coming. Seek feedback about your diversity, equity, and inclusion messaging for your facility and the PFAC from your group so that you can hear from them what is working and what could be done better. We want to eliminate jargon and work to keep that so that people know what we're saying. Share leadership with your providers, involve people in selecting your agenda items, and level the playing ground. Let's go on a first name basis and not use titles, especially for our staff and provider partners who are participating. I want to turn the time over now to our great partner, DeeJo Miller, and let her tell you about their experience with starting a special PFAC for Latinas e Hispanas. And I don't know Spanish, so I'm sure I murdered that, but let me turn it over to you, DeeJo.
Thanks, Lisa. And I'm going to share just some quick tips and ideas and things that we've learned over the years. So in 2008, we had a teen advisory board and a family advisory board at Children's Mercy. And one of our providers who hosts a bilingual clinic wanted to start El Consejo so that our Spanish speaking families would have a space of their own that would give them the bandwidth to be able to share in an environment that was comfortable for them. And we learned a lot of lessons. And first is really bringing on an advisor, a PFA, at the very beginning so that you can understand those nuances and start that collaboration right off the bat of this is a partnership and we're going to create this together. So then that will also lead into the rest of the PFAC members that understand, and for our members, they always tell each other when a new member starts, They reassure the new person joining that the hospital listens to us. We helped make this council. So what we learned was that we needed to create that safe space for these members. So what that means is that physically we met off-site for many years so that they didn't have to go through security to enter into our hospital. Originally, we met in an off-site clinic, so you didn't have to show your ID. It's not a requirement that you be a citizen or have ID to be a member. Their children experience care at Children's Mercy, and we wanted to be able to hear from them. So we met off-site, which also not having them integrated right into our family advisory board gave them that environment to learn together and just to culturally meet their needs that was different than the family advisory board. The family advisory board is very structured and has high-level administrative leaders at the table, and Consejo is less structured. There are minimal staff members at the table, so that the feeling of power is with the parents. But we do have a provider champion. We have others that are a part of the Consejo so that they can hear what's being said and make the changes at the hospital. So they, we've asked them even over the years if they wanted to have a dedicated seat on the family advisory board or have some integration, and they have told us time and time again that no, they don't. They want their space, they like their space, and it's an amazing space, and we've learned from them. So, but we do like to give them that choice. Also, we do have an interpreter at every meeting for the English speaking staff. I am not bilingual. And anyone that comes to present needs an interpreter. So the shift in power is towards the members, and that has really built a strong, trusting foundation with them. So one of the things that we started with, and here's the picture of their families. So in the early days, whole families were invited to the meetings. This helped the spouses feel comfortable with what the what they were, their spouse was joining and being a member of, to learn and understand what that was. It was easier for the family to come, so we would all meet together. We had dinner catered in from a grocery store that did catering because we were off-site. And then we had volunteers that would take the children into another room, and husbands and wives would be a part of the meeting. Over time, the husbands stopped wanting to come, but once a year we have an annual meeting where the whole family is invited to come and again share a meal, and we take time during those annual meetings to celebrate their accomplishment in front of their families so that these members can be applauded and celebrated. I talk about the impact of what they had done over the year, the impact in the hospital, the impact in the community. I talk about at the national level, I'll tell them about this presentation and how they were shared as an exemplar example. And then they're presented with certificates of achievement and thank you gifts. Our department has budget so that we buy logoed items for all of our PFAC members to thank them for their time serving the hospital. And for the meeting content, we started out with presentations about the hospital, the services, and from the questions that they asked, that's where we realized there were gaps. And that's where we built future meetings on. And so For recruitment, we utilize the members recruit, and our interpreters recruit, and our providers recruit, and they just created a bookmark with a QR code that can lead people to their website, the Consejo site on our Children's Mercy page, so that others can learn about it and come and experience a meeting and then decide if they want to join.
Okay, thank you so much, DeeJo, for sharing about your Consejo and how important it is to Children's Mercy and understanding the needs of this important segment of your population. I have a question for you about how many persons, about what percentage are they representing of your total patient population?
So our Hispanic population is, I'm thinking, Cheryl, you can help me, 18 to 20%. And so then we did do a PFAC demographic survey a few years ago. And we did that in conjunction with our research department, so that our PFAC members would be comfortable that they weren't sharing their personal information with us as leaders. And we recognize that Consejo represents a population on a separate council, and it's not integrated, although there are members on other PFACs who are Spanish speaking or more bilingual, and choose to be on some more demographic specific PFACs. Cheryl shared in the chat about an article we published about doing that demographic survey.
Cheryl, you are right on it. How on top. So I appreciate that. Cheryl and DeeJo are a team at Children's Mercy, and I have been so fortunate as to have a tour given to me of Children's Mercy's facilities by Cheryl, and they are probably one of the best PFACs and PFAC multiple PFAC efforts in the country. So I've included DeeJo's contact information in this presentation, and it will also be on our list of how-tos that will reiterate what we have just said today. You will receive this as an email if you registered for this event, and you can also find it by going to www.patientsafety.org, which is the Consumers Advancing Patient Safety website. Look for it under resources. And this time, because you asked for a slightly bigger font, it will actually be one page, but it will be the front and the back of that one page. So thank you so much, DeeJo, for your expertise and sharing that. Armando has made some really great points in the chat. He pointed out that we want to have diversity on the staff as well, so that we don't have all people from one background, one service line. They shouldn't all look the same. And for example, we had a hospitalist on our staff who, yeah, she was a doctor, but she put her way through school and had come from an extremely impoverished family, and it was great to have her and have her background and perspective. And Armando also points out that diversity, equity, and inclusion should also include patients who have experienced harm, which is one of the ways you can find patients, is to go to your quality office and ask them for patients who came to them about issues they had, and especially those who came with a let's solve this mindset instead of a let's complain about it mindset. Now, Armando, you can tell a little bit about your program that you have. This is the contact information, but tell a little bit about what H2PI has to cover these kinds of issues for patient and family advisory councils.
Sure, thank you, Lisa. So at the onset of the pandemic, we realized quickly that, because of all the restrictions, you couldn't be there in person to help organizations develop a PFAC, or even reinvigorate a PFAC that's been in existence in their hospital. And so we developed this platform that is based on learn, do, and inspire. And so we developed now we have three programs. We have a entire PFAC journey from start to finish. And you even get a certificate at the end. And then we have a mini course, which actually allows you to take your existing PFAC and re-energize it. And then we developed a brand new state-of-the-art PFAC 2.0, which is really taking your PFAC to a whole level, like and engaging your PFAC community members into these committees that are based on quality and safety. So like infection prevention, like sepsis, this is not easy things to embed your PFAC into it, but if the organization is open to it, certainly that's what we call 2.0. So, I don't want to tell you too much about it because of time constraint, but I will tell you that you can always reach out through our website or directly to me and request a demo, and you'd be surprised. It's really based on artificial intelligence, and it's just phenomenal program. So thank you.
Thank you. Thank you so much, Armando. And Armando's contact information will be included in the one sheet that you receive. We want you to save the date and register, and this link will also be available on the information we send out to you for our next event, which may be one of our very last in this series, which is choosing Patient and Family Advisory Council discussion topics. It's one of the big questions that we get. What are we going to talk about? And I promise you that if you follow the guidance that we give you, you'll have so much to talk about. You won't know what to do with all the requests that you'll receive. So I think some of those of you who have active, ongoing Patient and Family Advisory Councils can attest that this is not a challenge once you get really going. So let's help you get going. Next time, April 12th, again at 2:00 Mountain Time. That's where I'm at, in the mountains, and 4:00 Eastern Time. We'll look forward to seeing you. Thanks everybody for coming today and sharing this time with us.
Thank you, Lisa.
Thank you. So long.
Okay.